Matt. Next up with our PQI clinical overview is Andrew Kowalski, PQI2 oncology pharmacy resident at Yale New Haven Health in Connecticut. Andrew will speak about the PQI that he co-authored with Sam Abdelghani, pharmacy manager at Smilo Cancer Hospital, on Copanlisib for the management of relapsed refractory follicular lymphoma. Andrew.
Thanks, Steve. So I just want to take a few minutes to go over the PQI that I wrote. Start off a little background information. Follicular lymphoma is the most common subtype of non-Hodgkin's lymphoma, which includes both a variety of aggressive and indolent malignancies, follicular lymphoma being more on the indolent side of the spectrum. But patients with relapsed and refractory follicular lymphoma do have limited treatment options based on the NCCN guidelines. And Copanlisib is actually FDA approved and included in the NCCN guidelines after patients receive at least 2 lines of previous therapy. This FDA approval was based on an article that was published in the Journal of Clinical Oncology in 2017, which is a phase 2 trial of Copanlisib by Drayling and colleagues. Copanlisib takes advantage in its mechanism of action of the overexpression of phosphatidylinositol 3 kinase, or PI3K inhibitor, that is usually overexpressed on B-cell malignancies. So Copanlisib inhibits this pathway to cause this mechanism of action. It is actually the second drug on the market following the oral version of a PI3K inhibitor, idelalisib, for follicular lymphoma. The main difference between these 2 drugs is that they have unique toxicity profiles and that idelalisib is an oral drug, whereas Copanlisib is intravenous. Next slide, please. So when you receive an order for a prescription for Copanlisib as a clinical pharmacist, there's a few things that you should be aware of. The first is to make sure that it's being used at an appropriate place in therapy. So per guidelines and package insert recommendations, it should be received following for patients that have received at least 2 prior lines of therapy for follicular lymphoma. So it's very important to check that. And then also there's a unique toxicity profile associated with Copanlisib as well. The first one is an increased risk of infections, including bacterial, viral, and fungal infections, but also PJP infections. It's not actually recommended to do upfront PJP prophylaxis for patients, but if a patient is suspected to have PJP infection, they should be treated with Copanlisib on hold. And then once the treatment is completed for the PJP, you can resume Copanlisib, but with secondary prophylaxis on board for PJP. Another important consideration is the potential drug-drug interactions with Copanlisib as a major CYP3A4 substrate. The package insert does recommend to decrease the dose of Copanlisib if this is necessary, but it also recommends preferably to avoid any potential drug-drug interactions. If you do need to use a strong inhibitor such as voriconazole with Copanlisib, it's recommended to dose reduce from 60 milligrams to 45 milligrams given on the same dosing schedule. Mind you go to the next slide, please? So some of the more common side effects that are associated with Copanlisib include hyperglycemia and hypertension. In fact, grade 3 hyperglycemia occurred in 25% of patients receiving Copanlisib in clinical trials. And it's recommended that we monitor blood glucose at least pre and post infusion. And it's recommended to hold until the fasting blood glucose is less than 160 or the random blood glucose is less than 200 milligrams per deciliter. And they also recommend specific dose reductions in the package insert if at any time the patient has a blood glucose recorded above 500. The hypertension associated with Copanlisib occurs in about 30% of patients and is often transient, usually remaining elevated anywhere from 1 to 8 hours post-infusion. So it's also important to check blood pressure pre and post-infusion and to discontinue if life-threatening. If it's a mild elevation in blood pressure, you can use appropriate antihypertensives. And the next slide. So as a clinical pharmacist, it's important to be able to counsel a patient and make them aware of things they may not be aware of as far as what could be associated with a drug toxicity, particularly things like confusion or a headache, maybe indicative of some of the more common toxicities associated with Copanlisib, such as hyperglycemia or hypertension. But it's also important to make sure that they can be aware of the risk of an allergic reaction, the infections and pneumonitis, and then also diarrhea. With that, the next slide has my references, and I'll take any questions from any of the members on the line.
Great, thanks, Andrew. I want to let everyone know that we are opening it up for questions from our members, so feel free to utilize the chat or Q&A box or the raise hand function. But Andrew, thank you. And did also want to make note that this PQI is now available on NCODA's website, ncoda.org/PQI. Andrew, looks like we have a question that came in, and one of our members asks, in your opinion, what are some of the main takeaway points from your PQI?
Yeah, I think that's a good question. Thank you for the question. I think for me, the biggest take-home messages would one to be, as an oncology community pharmacist, I think it's important to be able to assess the appropriate role in therapy. So that patients could be receiving this drug anywhere after receiving 2 lines of therapy, I think is a big takeaway. So it doesn't need to be one of the last drugs given, but it also shouldn't be a first-line therapy. And then the other thing I think that's important to focus in on is this drug, like many other drugs used for lymphoma, has a significant risk of infection. So I think it's a good role for the pharmacist to be able to recommend appropriate supportive care and interventions, maybe when it should be more suspicious and when we should hold the dose. I think all those things are important to be aware of with this drug. And then, of course, drug interactions, I'd say, is probably one of the top 3 that I'd like you guys to be aware of, too, because a lot of the supportive care drugs that we use for our patients with lymphomas tend to have interactions with CYP3A4. So it may be something that physicians might not be as acutely aware of. So I think that's a good thing to keep in mind as a result of this PQI.
Okay. Well, thanks, Andrew. If any other questions come in, we'll be sure to get those over to you. But for now, again, the PQI is available on NCODA's website, ncoda.org/PQI, and a video recording of this presentation will be made available on NCODA's website directly after the presentation.